Welcome to you all in this health economics course. Today we will start with a basic introduction about health economics. This course, as it intends to address the students who are from economics, who are also not from economics. As the name suggests, health economics is basically a marriage between health sciences and its economic implications. When I was doing my doctoral research, people asked me that what is my research area. So broadly I used to say this is health economics, and they were asking me that health economics, what is that? I would like to take you through a 20-hour session where you will learn the nitty-gritties about health economics in a broad way. And I will like to mention that this course intends to benefit the students of economics, of healthcare or allied subjects which connects the health and economics together. Now, coming to the health economics, I will first talk about what is health. According to the definition by World Health Organization, health is a status of complete physical, mental and social well-being. Now, when I say complete physical, mental and social well-being, everything connects to health. And to be very specific, their health status. You ask me, how are you? I will say, I am good, I am not so good, I am having fever or I was having fever. So whatever I am specifying about my health is basically health status. When I talk about health status, then somebody asks me, okay, if you are not well, did you consult a doctor or have you taken a medicine? This health status, now I link it to health care service or my demand that whether I intend to go to a doctor or I casually leave it. When I talk about my coughing problem, they may ask, do you smoke cigarettes? That is my behavioral problem, my demand again. So the health status, health connects to the health status connects to the service and demand for health or health care. So health economics is basically connected to health care economics. Many often we come across the health economics as synonymous as economics of healthcare or healthcare economics. Therefore, now after giving a broad definition about health or health economics, I will go back to this economics little bit and try to introduce the economics for whom those who are not coming from economics background. Why do we study economics? I ask my students, those who are not from economics background, they say it's a study of money, finance, this, that. Let me say, economics is not actually accountancy. Economics we study primarily when we have one, limited resources, and two, unlimited demand. I mean, we have enormous demand in our life, but we have limited resources. I want to live 150 years, but I have limited resources. I want to be healthy every day, but I have limited resources in terms of be it pollution, be it availability of doctors, be it the medical facilities otherwise, be it my food habit. So everything has a limitation. Also, finally comes to my budget constraint. So even if I have an unlimited demand, I also have limited resources to meet that demand, because it's not only me, there are millions and billions of people who have enormous demand, and that particular resources which is limited in nature are serving those infinity amount of demand. Therefore, we need to have choices that given those limited resources or scarcity, how best I can maximize my demand or maximize my satisfaction based on my demand. I have to choose between different resources which are possible given my constraints, my budget constraints, my time constraints, my cost constraints, my production constraints. We will talk about more about these constraints when we go along. And we also have to choose in a way that makes my choices efficient, so that I can say that I have gained the most given the scarcity or the current limited circumstances. Therefore, when I talk about these three aspects, that limited resources and unlimited demand given, and I will like to maximize my efficiency given the choices. So in economics, we would like to bring them down in 4 basic aspects. So the first one is costs. Every activity we do, it has some cost. It can be monetary cost, it can be non-monetary cost. And the cost is in terms of, here we say in broad, resource use. Every resource we use, it has some costs associated with this. We pay monetarily or we don't pay monetarily. There can be, like, say, an example of non-monetary cost can be time cost. For an example, I go to a doctor and I pay the fees to the doctor. That is my monetary cost. My non-monetary cost is because I am going to the doctor, I am not going to work maybe for that day, right? Or I am spending some time, even if I am paid for taking leave, so it doesn't culminate to my doesn't have an implication to my monetary cost or monetary loss, but at the same time I am losing my time, which could be utilized in some some other way which could be productive. I am being assisted by my family members. They could not work or they could not do anything else which could be productive otherwise if I am not going to visit a doctor. Eventually, in a country like India or any lesser developed countries, we see that there is a high cost associated for the poor underprivileged villagers who stay in remote areas, have to come to urban cities to visit a hospital or a healthcare provider. They are not, mostly they are daily wage earners, or their income comes from their daily activities. So they are losing their income, their family members are losing their income, and their time cost, their travel cost, even if they don't pay or they pay. So the cost is in terms of resource use. It can be monetary as well as non-monetary. When we study about health economics, it also discusses about the payment mechanisms and who pays for that. In several countries, I will take an example of, say, UK, where the health financing is basically done by the government through taxes. We can talk about USA, where the health financing is mostly private in nature. The healthcare providers are private. The people who are visiting a doctor or a healthcare, they are paying either from their insurance or from their pockets, so because they are private. Next, let's take an example of Canada. In Canada, some part is provided through taxes by the government. In some cases, the doctors or the healthcare providers are paid by insurance companies. In India, it's very, very mixed in nature. In India, as the healthcare providers are very, very mixed or diverse in nature, we have quacks who give, who put some powder, even if there is a snake bite, there are quacks. There is government doctors, there is private doctors who serves village people, there are private doctors who charges high serving this or consulting in tertiary care super specialty hospital. So the nature of our healthcare system in India is very, very diverse and very sparsely distributed. Therefore, our healthcare or our healthcare behavior is highly determined by the doctors or the healthcare providers, hospitals, private or public, where they are located, what kind of problem I have, whether I am paying from my pocket, which is mostly the case in India or in any lesser developed countries, as well as whether I am paying from my insurance or my insurer pays for me, or I am being paid through some schemes, because I am a central government employee, or I am associated with some government scheme, being a below poverty level card holder, BPL card holder. So my health seeking behavior is determined based on who pays for my healthcare and what is the payment mechanism, and the costs associated, because I am meeting that cost based on this healthcare payment mechanism, is all directly connected with that. The next is the benefits what I get. I estimate the benefits against the costs. I mean, what I am gaining visiting a doctor, what I am gaining by my healthcare behavior, a healthy behavior. I smoke a cigarette, what I am gaining or what I am losing. And after I have some lung infection, I go to a doctor, what I am gaining and what I am losing. Because I pay for the cigarette here, and later I pay for the doctor, in which way I want to seek my satisfaction, or which way I find more benefits against my payments, be it in cigarette, be it on towards the doctor, or my treatment processes. The next is the choices I make. Now here, as I said, that based on the cost, it comes, I look at the benefit, that whether I pay for this or I pay for that, and what kind of benefits I am getting based in comparison to the costs I am incurring in different aspects. So I have choices, right? I have different choices, and I have to choose the best one. And when I talk about the efficiency, I will choose the one which gives me the highest efficiency, and efficiency is very, very relative. I can gain satisfaction by smoking a cigarette. You can say that, sir, smoke causes cancer, don't smoke, and you gain benefit by not smoking cigarette. So it's very, very individual level. Therefore, again, when I go back to the choices, I make my choices based on how much payment I am making for a particular decision, be it healthy or unhealthy, or what kind of choices I make, that I want to go to a homeopathy doctor or an allopathic doctor. Maybe the homeopathy will take me longer time, or an Ayurvedic doctor, maybe it takes a longer time, but I don't have to go for a surgery. For allopathy, maybe I am paying more, I am going for a surgery, causes me pain, but at the same time my treatment is faster. So you have got several choices, and you have to see which is the most efficient for you. Maybe a surgery is not recommended for an elderly person, so they can choose for a allopathic or homeopathic treatment. They can. I am not saying that that's the best or that's the worst. At the same time, for me, I need to join a hospital, join my job. I can't stay at home if I have twisted my leg, and then I can't choose a healthcare process which takes longer time. So again, I am deciding about which is my choice and what is the implication in terms of my benefits, and the benefits are very, very, again, subjective in nature. My benefit may not be similar to your benefit, therefore my choices may not be similar or are not similar to your choices. Therefore, when I see a half-filled bottle, and then I say, if I am a pessimist, I will say that this bottle is half empty. If I am an optimist, I will say that this bottle is half full. If I am an economist, I will say this is an inefficient choice, because you can't afford to keep this bottle half empty. You are not making the best of your choices. Now, I will introduce two concepts, micro and macroeconomics. Micro and macroeconomics. What is the difference between micro and macroeconomics? Microeconomics, as the name says, it's small. Micro means small, isn't it? So when I talk about microeconomics, it talks about individuals, any human being, individual, a singular sense. Two, households or the families. We generally in research terms in social sciences we call households mostly. I'm not saying that family is a wrong term or on non-scientific term, but generally it's known as households. So households again is a unit, as a unit which takes economic decision, which takes the healthcare decision, and then they can relate it at the household level as a small unit. And third, if it's a community, community as a unit, a small community is a small unit where there is a homogeneity in terms of the health-seeking behavior or healthcare provision, or both the supply and demand side, if I take together or separately. On the other hand, when I talk about macroeconomics, macro is a large concept, so you can say it's a state or district. It's a state or district. It can be a country, or it can be an international perspective across countries. Yeah, so that means whenever some economic decisions, the relationships between economic variables, economic theories are encompassing different countries, state at the larger context, then it is macroeconomics. When it talks about the smaller context at an individual level, at a household level or a small community level, it talks about microeconomics, and the expanse of these microeconomics and macroeconomics are very different. So whenever we are talking about a policy, a government's decision about how much to pay in a health budget, or an international NGO spending, say World Bank or Asian Development Bank or some international NGOs, right, BMGF, how much they are paying for a particular health cost for a particular country, their investment, these all are the macroeconomic variables or macroeconomic decisions. And in terms of my health, my expenditure towards my treatment seeking, say how much I paid during a particular year for myself or for my family or household, or what is the health insurance mechanism at a community level or a community financing mechanism, we can talk these under microeconomic theories. Now, when I talk about efficiency is, when I talk about efficiency is basically an optimization concept. When I talk about optimization, here in this healthcare economics, we talk basically about maximizing benefit given resource constraints. Maximizing benefit given resource constraints. Therefore, when I talk about this maximizing benefit given my resource constraint, we can deliver to this topic two ways. One is technical efficiency, another one is allocative efficiency. Technical efficiency and allocative efficiency. Now, what is technical efficiency? It's like meeting a given objective, that you have an objective, you want to achieve that objective given cost or cost constraints or certain budget. To attain, say, let us take a production or the level of immunization, that I want to complete immunization for children less than 5 years old of age. All 5 years of age children should have complete immunization against certain listed diseases. To attain that objective, if I can utilize my resources in the best possible manner so that I can limit or keep my cost lowest or least, then I achieve my technical efficiency. So my resources, it can be capital, it can be labor, it can be human resources, it can be non-human resources, and its cost implications. So if I can deliver the best in terms of healthcare, health status, health achievement given my budget constraint, cost constraints, then I am achieving a technical efficiency. Whereas in terms of allocative efficiency, we look at the dynamics where supply is equals to demand. That is, when I as a service care or as a government or a policy maker can ensure that the supply of healthcare providers, the number of primary health centers, the number of doctors per thousand population, the number of nurses per thousand population, the number of beds per thousand population, I am meeting that demand based on the, with my supply. Yeah. So, and that can vary. Maybe in Calcutta, where dengue is very high nowadays, whether I am achieving the level of supply of doctors or the the requirements based needed to this dengue treatment, I am meeting that requirement or not, given the higher prevalence rate, higher percentage of dengue cases or incidence rate of, that is the new cases in a particular year of dengue in a particular locality or a city or a state, whether I am achieving that. So then I am meeting a supply equals demand. Maybe dengue is not the case in Gujarat, there is a higher proportion of diabetes. At the same time, I will look at whether in Gujarat the requirement for the diabetes treatment is being delivered based on this, the requirement of this of the general population, based on the prevalence rate or the percentage of diabetic population in that particular state during a particular time period. Now, health economics basically talk about, I come back again to health economics, it also encompasses pharmacoeconomics. They are not very different than health economics. Pharmaco is the pharmaceuticals. Yes, so this is the economics, which talks about the drug therapies of the the consumption of a particular medicine for a particular disease, its effectiveness, the cost of that particular medicine, and how best it is reducing that particular disease prevalence, or how effective is that. Therefore, when I am talking about this effectiveness, this pharmacoeconomics and healthcare economics mostly talk about or largely talk about economic evaluation. We will talk about this economic evaluation for a couple of hours later during our course, and this economic evaluation is the most sought for concepts from the health economists. So, what is evaluation? I want to evaluate something, right? What do I evaluate? I evaluate a particular implementation. It can be, when evaluation is, we know that when I write an exam, after say 1 year of a course or 2 years of a course, when I write an exam, my teachers are evaluating me, right? Not me, basically my learning. Similarly, so learning is my outcome here, which my teachers have delivered to me, and I am trying to understand what has been the effectiveness of that learning process on me. I do better or I do bad, that is subjective. That is again, varies from person to person, their efforts and many other things. In healthcare, the evaluation we do generally of a particular treatment or a treatment mechanism of a medicine or of some implementation. I give some vaccinations, I give some immunization technique, I deliver some awareness campaigns, and its evaluation on the health status of that individual, of the household, or of that community as a whole. Therefore, in economic evaluation in healthcare, we basically try to understand that how effective a particular treatment process, a particular medicine has been for a particular target population. In a nutshell, in health economics, when I talk about descriptive health economics, as economics by large has remained a quantitative or numerical subject, as a descriptive health economics, I keep it quantification of a particular phenomena, quantification of my health seeking behavior, that how many times I go to a doctor, depending my affordability, quantification of a particular disease, quantification of a particular medicine's effectiveness or on that particular disease, quantification of how much I pay or how much I lose, how much I pay for the treatment, how much I lose because I have the disease, with respect to I take the treatment or I don't take the treatment. At the same time, how do I pay, whether I have a health insurance, then what is the premium, if my government is paying for me through taxes, then how much they are paying, what is the percentage of GDP they are paying. So these are the basic health economic variables which I try to quantify and give them a number to describe the scenario of a particular population. When I talk about predictive, that means I am predicting something. I am predicting something, that what happens. Yeah. So when I am predicting something, I am actually identifying the impact of our change or implementation. That means how much change or how much impact a particular change in decision or a particular change in treatment process, a particular change in medicine, a particular change in health financing mechanism has brought in. So the impact of change or a particular implementation. So this implementation is my determining variable, my independent variable, and the impact is the dependent variable. So if you have a knowledge about regression, so here we are trying to understand the impact on the dependent variable based on some changes in the independent variable and how much that impact is or how much the impact can be in different circumstances. And finally, evaluative. Here comes the evaluation again. So when we are talking about evaluative, we are doing an economic evaluation of several healthcare processes. That means what is the effectiveness of process A, what is the effectiveness of process B, what is the effectiveness of process C, along many others. I have some cost implications for process A, B, C and others, and I have varied gains from A, B, C and others. Now it's my choice based on my preferences, based on my affordability or my conditions, that which would be my best choice, A, B, C or D. Therefore, evaluative says the relative preferences, at least they help us to make a relative preference. So, when we try to map a demand for health based on Grossman, I will have a extended session on Grossman's model of healthcare demand. We basically try to understand here the healthcare as the healthy days or a health stock. How many days I stay healthy, that's my health stock, right? If I am staying longer time period as healthy, then my health stock is strong, larger, that accumulates further, that I will be staying healthy for a longer duration of time for the later period of my life. Therefore, this health stock is basically determined by several health factors. It can be health care, how best healthcare I am enjoying or I have enjoyed probably since my mother's pregnancy with me. From there, her healthcare during her pregnancy, my birth, and my my health as a child, because that has a strong impact on my health as an adult, and my health seeking behavior or my healthy behavior starting from diet, the exercise, the environment, the income, the awareness. These all are very prominent determining factors which affect your health stock based on some production process. This is basically the Grossman's model. I'm just giving you the name here, Grossman's model. Thank you.